Hello, good evening, everyone. I am Dr. Hina Singla, Program Unit of Vision 2020 India, based in New Delhi. On behalf of Vision 2020 India, I welcome you to this webinar cum panel discussion on From Awareness to Action, Risk-Stratified Technology-Enabled Pathways for Diabetic Retinopathy, Screening to Treatment Adherence. We will run the session for 1 hour 15 minutes. Vision 2020 India has been organizing various webinars under its Knowledge Hub initiative. Let me introduce our resource persons. Our first expert is Dr. Padmaja Rani. She is Network Head of Ophthalmology, Teleophthalmology, and Vitreoretinal Surgeon in LV Prasad Eye Institute, Hyderabad. Her specific interest areas are diabetic retinopathy and teleophthalmology. She has more than 190 publications. She is author of Shankar Netralaya Atlas of Retinal Diseases and passionate in capacity building of optometrist and management of DR. Our next expert is Dr. Thomas Cherian. He is a senior consultant in retina and vitreous and deputy medical superintendent at Little Flower Hospital, Angamalai, Kerala. He has 30 years of experience in retina and vitreous and community eye health programs. He has been a member of different task force on various community programs. His areas of interest are diabetic retinopathy, community programs in retinal diseases, and vitreoretinal surgery. Our third expert is Dr. Vishali Gupta. She is an accomplished vitreoretin and UV expert of international repute working at Postgraduate Institute of Medical Education and Research, Chandigarh. She has more than 190 publications in peer-reviewed journals, has edited 4 books, and contributed 62 book chapters in textbooks. She is currently the Vice President of Uveitis Society of India, Chair of Scientific Committee for Vitreoretinal Society of India, and Secretary of International Uveitis Study Group. Our fourth expert is Dr. Judy Joseph. She is the consultant diabetologist at Little Flower Hospital and Research Center, Angamalai, Kerala. She completed her post-graduation from Amrita Institute of Medical Sciences, Kochi. Her field of interest is comprehensive diabetic care of young diabetic patients. The event will be moderated by Mr. Subeesh Kuyyadiyil, who represents the Central Zone on the board of Vision 2020 India and currently serving as a head of Center for Community Ophthalmology at Sadhguru Netra Chikitsalaya, Chitrakoot. He also playing a vital role in planning outreach programs, establishing primary eye care centers in rural areas, and leading international capacity building programs. We are also thankful to Orbis Cyberside for providing us the Cyberside platform. We appreciate the support from our corporate advisory board members, Appaswamy Associates, Aurolabs, SLO Luxottica, Forest, and Microflow for their continuous support. There is a question and answer box where you can type your questions and we will answer them at the end of the presentation. Thank you once again for your participation. Now I would like to request our first expert, Dr. Padmaja, to take over.
Thank you, everyone. Good evening, everyone. And thank you, Vision 2020, for this opportunity and very good job in creating these awareness seminars from World Retina Day to World Diabetes Day. So the first topic is, can technology help us in screening diabetic retinopathy better and safer? So I will present an ongoing project experience which we call it as Smart Drop. Smart means artificial intelligence enabled. Drop mean diabetic retinopathy outcomes and pathway, real world AI integration experience. This project is a ICMR funded project. We are doing in collaboration with IDEA clinics, which are 4 diabetes clinics in Hyderabad city, and also Indian School of Business. So this project idea is to conduct systematic AI-enabled tele-diabetic retinopathy screening program. And all these clinics are linked to LVP Image Reading Center, Central Image Reading Center, to validate simultaneously the AI technology and also to create a systematic DR pathway so that every patient with diabetes who walks in physician clinic will get a diabetic retinopathy screening check. And we have established 2 facilities. We established a Forest camera, and 2 facilities we established Remedio portable camera. And again, this is an operational research project, so we wanted to see how these cameras work and also their AI algorithms work. And in Idea Clinic, what we have created is a digital portal to create a diabetes registry so that all the patients who walk in into the diabetes clinic are entered into registry. And from there, the patients who are eligible for DR screening are enrolled into the project. And number of, if you see the target overall, it is around 60%. The target was actually 80%, that we need to screen the patients who are coming to the physician clinics. And among the gradable, if you look at it, the images, the quality is around 79%. And simultaneously, the same project, the project started in 11th March 2024. And from then we also simultaneously, we are also enrolling recruiting the patients in the project from the LVP, tertiary eye clinic pathway, to look at how systematic DR screening clinic screening at the physician clinic will be compared to the tertiary eye clinic pathway. So if we look at this figure, this says that just having cameras and technology is not enough. Initially, the first year, we have not established a free screening. We were actually offering diabetic retinopathy screening as a part of complication screening package for around 5,000 rupees. So then what happened was, initially the screening percentage, if you look at, it was around 32 to 50%, and it was not really taken up the target of 80%. Then actually we said that the free screening, diabetic retinopathy screening, will be done free, irrespective of they take the complication screening package or not. Then the screening numbers have increased. Then there is a drop again in the August and September due to some attrition of the team members, and then now again. So these are all the challenges, but one lesson that we have learned here is the diabetic retinopathy screening has to be offered like a free. Maybe it should be just a part of like how we check blood pressure and visual other vitals. The diabetic retinopathy should be offered as a consultation package rather than as a standalone another test. And when we look at idea LVP clinic pathway, if we look at, so the patients undergo checking with the PAP mobile application and followed by non-mediatic diabetic retinopathy screening. So what we have observed is the diabetic retinopathy, the no DR is more in ideanic, and definitely sight-threatening diabetic retinopathy was much more significant. And also we have, if you look at the vision, worse vision also was more seen in the LVP pathway. So this just slide indicates that when we do a systematic diabetic retinopathy screening physician, we actually can pick patients earlier and also with less retinopathy. So that is the importance of this diabetic retinopathy. But there is another challenge is about the referral pathway. So the patients refer from the physician clinics were around 25%, 75% could be there. And but the reach was only 16%. And among the reach also, the significant percentage which we reached were other retinal pathology. And when the vision less 26, and sight-threatening diabetic retinopathy in that order. So still we have a significant amount of patients who are ungradable images are supposed to reach to the next level. And we look at the screening performance in the 80 in the year one learning. So screen were paid when it was a paid package, it's 40%, but when it is offered as a free, it is improved to 80%. Referral, which was only 50%, that only when visual acuity is less or sight-threatening diabetic retinopathy. This is a challenge we are working on it. And image quality, which we call it as a hardware maintenance, non-mediatic camera, 80% was gradable in two facilities, whereas in two facilities it was only 50% gradable with the non-mediatic camera, where disc image quality was good, but macula images were poor, especially in small pupils. So this I would call it as a hardware maintenance, which we were talking with the camera people to improve the quality. Similarly, now coming most important aspect is our project is AI assisted, how AI was performing. So initial, when project started, there was especially the first quarter, there was a significant AA was giving very low specificity. It was only 60% of them were actually accurate, and the rest all it was giving for false positive referrals. So it was grading every image as a DR. So this I call it as a term called software maintenance. Then we have the camera people, and we also integrated human grading to just to see image if the DR is positive. The idea clinic technician was again grading to see whether it really false positive or not. But what happened was the significant improvement occurred after talking to the camera people, and then retraining and revalidation of the algorithm. You can see very clearly the initial, as I said, the specificity was 60% initial first quarter, which improved to now 94% over the time, especially after December 2024, by just talking to the camera and AI algorithm improving the software algorithm. So this is what I would say is the software maintenance. So, and also important is whatever the cases that are missed by AI, when we looked at, none of the sight-threatening DR cases were not missed by AI. Whatever the cases missed were only of the mild or mild diabetic retinopathy. So in nutshell, I would say in terms of software maintenance, they actually tweaked the algorithm. They removed from binary classification as DR observed and no DR to DR and early DR and severe DR, and that has improved the AA performance significantly, and improving the both sensitivity and specificity. So in summary, I would say more sight-threatening diabetic retinopathy and visual impairment will be detected in eye clinic pathway. So it is definitely most cost-effective way is to have actually diabetic retinopathy screening at the physician clinic at the first point of the cutoff will be the best approach. 75% can be managed at diabetes clinic, and 25% requires referral, and mostly ungradable images, and around 10% will be DR cases. Referral reach is a challenge, and visual acuity, when it is worse or other retinal pathology, those patients have reached much further than the other categories, and which we are still working on it. And free screening boosts uptake even with simple non-invasive test. We would say even it is kept, even still patient will want to keep it like as a part of consultation rather than a standalone test with a cost. There is a less acceptability. And scalable digital portal is very vital for linking diabetes clinic and eye care systematically. And trained technicians with DR grading skills will also have a better image gradability. As we say, in one facility, almost 89% was there. And non-mediatic imaging challenges again needs hardware upgrades, and R&D checkers are needed. And AI performance again depends on the camera software maintenance. And quarterly AI audits are essential to monitor and sustain the performance. So to conclude, I would say systematic screening, skilled technicians, robust AI, continuous audits together can make early detection in diabetic retinopathy scalable and effective, and also better and safe. Thank you.
Let me take this opportunity to thank Vision 2020 India for organizing this seminar and giving me a platform to talk about how and who all should we screen. Diabetic retinopathy is a disease which we need screening. The reason being, most of the cases of diabetic retinopathy, unless we screen, patients don't turn up for seeking medical care and treatment till they have reached a stage where they have vision loss, which is either reversible or irreversible. So this is a condition which needs screening. It should be a community screening, or should it be an opportunistic screening? That's all a debatable issue. But the bottom line is we need screening. Diabetic retinopathy is the most common retinal vascular disorder, which is asymptomatic in the early stages. Vision loss happens by the time it's symptomatic, and this visual loss could be reversible or irreversible. Awareness about diabetic retinopathy is inadequate in the community. Hence, till we reach that ideal stage where the community improves its health-seeking behavior and comes forward to screen and treat diabetic retinopathy, we need some sort of community screening. We have to pick up diabetic retinopathy and treat it from our side. This screening can happen either during a routine glass checkup. Patients, they come for a presbyopic correction around about the age of 40 or 45. when they come for this presbyopic correction at every point, be it with the optician, be it with an eye hospital or anywhere, we take a history of diabetes, and all those diabetes patients should be screened for diabetic retinopathy. Even otherwise, with every glass checkup, we need a fundus examination, not just for diabetic retinopathy, but also to detect glaucoma. So that is one stage where one avenue where we can screen. Then we have the diabetic clinics where the patients walk in for management of the diabetes mellitus. These could be a government non-communicable disease clinic, or it could be the diabetic clinics in many of the hospitals, the private hospitals or NGO hospitals, or it could be a vision center. The patient can walk in, they can go to a primary care physician for treating their diabetes. There also we could screen. Endocrinologists and diabetologists always get established diabetes, which is an avenue for screening. At the opticians level, we can have screening, and also we can have a screening in the community level. A door-to-door screening of diabetics can also be done. Now, how to screen? There are different techniques of how to screen a diabetic patient for retinopathy. The gold standard and the time-tested methodology of screening is the indirect ophthalmoscopy, which could be done by an ophthalmologist or in certain cases by a trained optometrist. But that needs a certain amount of training and expertise for screening. Second, again, to be done by an ophthalmologist or a learned optometrist could be a slit lamp biomicroscopic examination. The third one, it could be a dilated direct ophthalmoscopy, which could be done in the community. A non-mydriatic photography could be done again in the community or in an NCD clinic or in a diabetologist clinic. A mydriatic photography, ideally, we can dilate the patient, we get a better quality photograph. So that is a mydriatic photography. We also can have handheld cameras or AI-assisted cameras. Dr. Patmaja had just elaborated on the AI assistance for screening diabetic retinopathy. So this is how we do an indirect ophthalmoscopy, slit lamp biomicroscopy, or a direct ophthalmoscopy. Now, how to do the screening? Every patient with diabetes or every patient who is being taken up for screening need to have a refracted visual acuity examination using a 3 or a 6 meter visual acuity chart and a high contrast visual acuity chart. In the presenting visual acuity examination using a near and distance vision chart and a pinhole option if the visual acuity is reduced. Pinhole, again, only in the community, not in your ophthalmology clinic where you always need a refraction. Pinhole is not a substitute for refraction. Pinhole can be done in the community if needed. Presenting visual acuity examination using a 612 equivalent handheld chart consisting of at least 5 standard letters or symbols and a pinhole option if visual acuity is reduced. Now, retinal examination has to be done for a proper screening. That can be done with a direct or an indirect ophthalmoscopy or a slit lamp biomicroscopy. A fundus photography, a wide field to 30 degrees can be done. This could also use telemedicine approaches because photography can be caught in the community. If we don't have anyone to evaluate the photo there, it can be sent as a telemedicine item to the base hospital or wherever in the screening center, and it can be screened and diabetic retinopathy detected then and there. For the retinal examination, the examiner must be well trained to perform ophthalmoscopy or retinal photography, and the person should be able to assess the severity of diabetic retinopathy either manually or based on an AI fundus imaging. So when we are doing it in the community, either the person who is sitting there catching the photographs or examining should be able to say whether there is a diabetic retinopathy or no diabetic retinopathy. And if there is a diabetic retinopathy, is this case requiring treatment, requiring referral? That should be able to, information should be given to the patient in the community itself by the person who is screening. If that is not possible, a teleophthalmology-based screening can be done and a reply could be given to the patient based on this teleophthalmology screening. Or of late, we have AI-assisted fundus cameras, where the moment we catch the pictures, the camera itself should be able to say whether there is diabetic retinopathy and whether it needs referral. Now, in our hospital, while we were doing the screening from the community, we devised this 5-photograph concept just to give some patient education, because patients, when we say that we need to screen them for diabetic retinopathy, they are coming to an NCD clinic, a non-communicable disease clinic for management of the diabetes. They come, they pick up their tablets, they check their blood sugar, and they go back. The moment you say that you need to screen them, they were a bit reluctant for undergoing that screening. Why should we screen? Because we don't have any problem for the eye. So this is when we use this 5-photograph concept. We had this set of photographs for both the eyes, for the right eye as well as the left eye. Here, we show the first photograph as a normal fundus photograph. In the second slot, we inserted the patient's fundus photo, the right eye. In the third one, we inserted a picture of diabetic macular edema. In the fourth one, picture of a proliferative diabetic retinopathy, and the fifth one, a vitreous hemorrhage. That means your normal eye should look like this. Now it looks like this. If left untreated, it could go to this stage where your vision could be affected, or this stage where it could be affected a little more, or this stage which means blindness. So that message we have been conveying to the patient, and the same set of fundus photographs we have for the left eye also. Normal, the patient's fundus, DME, PDR, and vitreous hemorrhage. So unless we intervene now, it could go to the third or fourth stages, which are sight-threatening, or the fifth stage, that is blindness, and act fast and save your sight. This was the message which we conveyed in the NCD clinics to convince the patient about the need for a screening. Now, management plan, patients with less than adequate retinal assessment should be referred to an ophthalmologist, unless it is obvious that there is no diabetic retinopathy. That is a patient whose fundus doesn't have that clarity, media clarity to assess, or the photograph is not picking up. So such patients with diabetes should always be referred. Or mild non-proliferative diabetic retinopathy, if the examiner is confident that it can wait for another 6 months or 1 year, that doesn't need referral. Otherwise, that also should be referred. Any person with an unexplained visual acuity loss should be referred. Then, during the screening examination, patients with diabetes should be asked about diabetes control, blood glucose, blood pressure, and serum lipids, and also their nephropathy status. To women, about the pregnancy status, or whether they could be pregnant in the immediate future. Inadequate control and pregnancy may require further appropriate medical intervention. Now, whom to screen? People with known diabetes. It is not practical to pick up, to go to the community, screen the entire population for diabetes, and then pick up the diabetic patients and do a screening for retinopathy. So people with known diabetes, we need to screen them for diabetic retinopathy. Opportunistic screening could be done in patients who are above the age of years, who are attending clinics, and all diabetics attending diabetic clinics, NCD clinics, primary health centers, and vision centers. Have mass screening programs where we have specific camps for diabetic retinopathy screening as an outreach activity in individuals having 2-hour PPBS of more than 140 or FBS of more than 110. And targeted screening, people with diabetes, more than 5 years of family history of diabetes, or other comorbid risk factors like nephropathy, cardiopathy, neuropathy, obesity, metabolic syndrome. All these people have to be screened. And those patients who have less than 612 visual acuity, or where we have picked up a diabetic retinopathy, they need to be referred to the concerned ophthalmologist or the retina specialist, as the case may be. And these patients, once they reach the ophthalmologist or the retina care specialist, they can be taken up for further treatment in the form of anti-VEGF injections or steroid injections or laser or the surgery, as the case may be. So that's about how to do a screening and whom to screen. Thank you very much.
Yeah, thank you, sir. Our next speaker is Dr. Vishali Gupta.
So the topic which has been given to me is about risk-stratified technology-enabled pathways for diabetic retinopathy. So let's see, what do we understand by risk stratification? We do understand that we do have to stratify both systemic as well as ocular risk factors. And when we come to diabetic retinopathy, we do have a way of identifying low risk from the high risk population. If we identify it as a high risk, of course, it needs immediate attention, whereas the low risk can be monitored periodically by teleconsult itself. So that is why we need to be very clear about the models which we use for risk stratification. Now, how can we take the help of technology which will enable us for risk stratification? We all know AI-based diabetic retinopathy grading, and we heard Padmaja Thomas talking about it. It has actually been validated very well for Indian populations. So we have the camera which screens and which tells you with fair amount of certainty whether it is high risk or low risk. We also can use the model of teleophthalmology platform links with the optometrist and specialist and the cloud-based system which enable triage and longitudinal tracking. We do have mHealth tools for education, reminders, and follow-up, and all these seem actually very good when you look at them. The problem is putting them to practicality. So, what can be the proposed risk stratified pathways? These are very standard. There is nothing new which I'm saying. So, it is like if it is a low risk, which means there is no diabetic retinopathy, it is the AI camera which diagnoses this. If you do not have AI enabled camera, ideally it's a combination of AI being done by an optometrist or a technician, and the patient can be called 1 to 2 years tele follow-up, no need to go to retina specialist. If it's a moderate risk, again, we do the same thing, but instead of 1 to 2 years, we make the follow-up at 6 to 12 months. However, if it is high risk, which means there is a vision-threatening retinopathy and patient needs immediate attention, then we need an urgent examination. And once the examination is over, once the treatment is done, the patient still needs to be under follow-up. So what is the model? The model is actually hub and spoke model, where we have one center controlling and multiple hubs. These models have been done in different states. Tamil Nadu, Maharashtra has done AI-enabled diabetic screening vans using and doing it. Kerala has developed a beautiful model. Arvind and LVP have integrated the mid-level ophthalmic personnel, like LVP has Vision Center and Arvind has their own centers, peripheral centers where they use it. And we are coming up now with the concept, and View Council is one of that, which represents public-private partnership. So, but there are certain barriers and there are certain enablers. The barriers are issue of connectivity, cost of AI, inconsistent follow-up, and gap in the awareness. Whereas enablers are, we do have National Digital Health Mission. There is a lot of cloud space available in the government setting which can be used for these models. We have loads of local AI innovations and, of course, government support. So there has to be a collaboration between policy, technology, and clinician. And this collaboration should be consistent, streamlined, not one way, or it cannot be just a short-term collaboration. So what is the road ahead? The road ahead is we develop National Diabetic Retinopathy Registry. We do not have in some pockets in some states, for example, state of Haryana, they are registering all the diabetics, not the retinopathy in particular, but for diabetes, there is a registry. And however, the data is not really very optimal, the data entry. We need to integrate diabetic retinopathy screening into the primary diabetes clinic. And I think that is very important because the diabetic screening, when we check blood sugar or whatever, we really do not check for diabetic retinopathy. And I think this is what we should put our money on, that anybody who is diagnosed with retinopathy should have an integrated diabetic retinopathy screening. We need to scale up risk-stratified tech-enabled diabetic retinopathy programs, and technology, we all understand, has to empower us and not replace. So when we talk of the spokes are like the wheel and the multiple spokes. So what could be these spokes? I mean, what are the primary care contact for screening? They could be PHCs, CHC, community camp, NGOs, diabetes clinics, and even schools for screening drivers or the staff of the school who may be diabetic. Who should be screening? Again, we do have ANMs, pharmacists, technicians, vision technician, optometrist, and of course, we should use the staff of Ayush. Ayush has a huge manpower now and beautiful infrastructure. I think diabetes is one area where we should join hands with Ayush. And what should be done? Capture the basic data. And I think capturing the data very honestly, we do have EMRs, we do have cloud, but the person who's entering the data does not enter the data, and that defeats the whole purpose. We should perform fundus imaging using portable non-mediatric camera or even smartphone adapters, and these images are then uploaded on the cloud. So when we talk of what are, we have done it, but we need the edge intelligence, which means the automated images should be quickly checked in case we are not doing AI model and we are doing the telemedicine. The grading should be done immediately with immediate risk category. And we have very, three things. One is no diabetic retinopathy, which could give you green signal. It could be amber signal, which means you are somewhere at borderline. You need to be regular with follow-up. And it could be red signal that within next few days, the patient has to reach the retina specialist. So I think this coding will be very useful because nobody is going to read mild NPDR, moderate NPDR. But the moment we put the red sticker and says immediate referral required, it would kind of be known by all the people, whether it is ANM or ASHA worker or the attendants of the patient. Then we also have teletriage, which means that remote optometrist or ophthalmologist should be put at a hub, and retina specialist is only for the red cases. So optometrist can review the cases. If it is non-referable, they follow locally. If referable, and this is where actually we failed, where we had a Niti Aayog project where we were trying to develop, we could not figure out a very good, referral tree. We could screen the patients, but then all of them were referred to PGI, and it really did not work for the patients. You want me to find out? And so I will quickly go about the practical implementation plans. I think we need to run the pilot projects where we need have the models to train and execution. And I think we can discuss all these things where how do we involve the community, and there is a proper roadmap starting from the point of contact till the tertiary care center, which is actually friendly for the patients. We do need KPIs to track, and they are very specific KPIs like what percentage screening coverage, what percentage of image is readable, what is the referral rate, what is the percentage of referred patient who actually reach the hub, and time for screening, specialist decision, treatment uptake, visual outcomes, and cost per patient. When we did it in the community screening, what we found is that it's good. You can put up a camera, no challenge. You can even train the local A&M to take the photography. Like we train them in 2 weeks, all fine. You can diagnose vision-threatening retinopathy, all good. But when it came to referral, patients had a reluctance. We just had about 25% uptake for receiving the treatment. So even after diagnosing, the patient did not actually reach the retina specialist. And out of those 25% who reached, just 5% completed the treatment. So I think till the time we have a very solid plan of referral and from spoke to hub, we are all busy developing multiple spokes and we say, oh, train Asha worker, train this, fine. That part is one. But till the time we have a hub which is connected to the spoke in a very seamless manner, and I think we need to pay attention right now to this rather than first developing all the peripheral methods for screening and then leaving those patients in lurch, because then the next group of the patients automatically feel nothing happens. These guys just come, they screen you, and they leave you. So that's not a good message for any program which is taking off. So I think that part is fine. And of course, we have to be very aware of the privacy concerns and where we are collecting the data and all. So common barriers are basically the connectivity, image quality, patient's loss to follow-up, and the cost. And I think all these things should be taken into consideration before we actually talk about the technology-enabled stratified, because we do have technology, we do have very standard stratification. The problem is that we have to have a very solid grounds, how do you actually benefit the patients? And that's what I have to say.
At the outset, I would like to thank Vision 2020 for giving an opportunity to speak in this forum. Well, my topic is about integrating diabetic retinopathy management into comprehensive diabetic care. Well, the agenda is about understanding diabetic retinopathy within diabetes, importance of early detection, screening, integrating management approaches, challenges and solutions in integration, and impact on the patient outcomes and healthcare systems. Understanding diabetic retinopathy, as you all know, it is the cause of diabetic retinopathy is mainly the blood sugar levels damages the retinal blood vessels, causing diabetic retinopathy, and this leads to visual impairment and blindness. As you all know about the prevalence of diabetic patients, about 17 to 27% of the diabetic patients are always diagnosed with diabetic retinopathy, and it depends on the longer duration of diabetes as well as on the poor glycemic control and on other patient demographic factors such as age and ethnicity also. As risk factors and progression, the poor glycemic control, hypertension, long-standing diabetes and poor lifestyle interventions and diabetic nephropathy also plays an important risk factors. And recognizing the disease progression allows for the timely intervention and better patient outcomes. So what is the importance of early detection and screening, as already told by our previous speaker, Dr. Thomas Cherian? I won't be going into that. Now about the integrative management approaches. there should be a coordinating care between the diabetologist and the ophthalmologist. Like a clear and ongoing communication between the diabetologist and ophthalmologist usually improves the care quality and coordination in these patients. And developing shared care plans ensures that timely intervention is being performed for these diabetic patients' eye health. Incorporating the diabetic retinopathy in the diabetes like you to have a diabetic management that ensures a comprehensive treatment for the patient's well-being, and a coordinated care is very important in these patients. What are the challenges and solutions in integration? Actually, there are the barriers like previous Dr. Vishali has told, that there's a communication challenges also, which provides disrupt in the coordination affecting the patient care, the resource constraints, and the patient non-compliance. Even if you detect them with diabetic retinopathy, they don't come to you for the treatment. And then we have the innovative models of the collaboration care that is a shared, and the technologies like just how our first speaker, Dr. Padmaja, told. So what are the impact on the patient outcomes and healthcare systems? So improving the quality of the patients, like early detection of the vision problems is crucial to prevent the severe impairment, and you have to give a coordinated treatment and maintain independence and minimize the visual impairment will help the patients maintain their overall well-being. And even the cost reduction, like if you detect the diabetic retinopathy early and instead of going into other main further managements like surgery and the last resort, if you could detect it early and give them the proper treatment, it would be also reducing the cost of the treatment also and the financial burdens in these patients. So the long-term benefits of integrated care is you have the improved patient adherence, and which gives treatment leading to better health outcomes. There will be reduced complications by ensuring continuous and coordinated care, and efficient healthcare delivery will provide a more efficient and effective healthcare benefit to the patients and the providers alike. Thank you.
Yeah, thank you, Dr. Judy. Now I request Mr. Subeesh to take on for the panel discussion.
Thank you, Dr. Hina.
Yeah.
I think first of all, I really wanted to thank 4 excellent speakers, really putting insight on diabetic retinopathy. Just wanted to congratulate Dr. Padmaja, Dr. Thomas, then Dr. Vishali, and Dr. Judy. And we all know, most importantly, the participants are largely from community eye hospitals. And these insights are really going to help them in terms of how do they improve their own diabetic retinopathy services, especially in the remote and very less resource intensive areas. So in the interest of time, I would like to go with one-on-one with the speakers. Maybe first with Dr. Padmaja, your talk was really excellent, where you could really demonstrate how important to have free screening, because if you look at diabetic retinopathy, this is not something very popular, so we may not be getting that acceptance. We start with kind of asking for payment for the services. That's what you could show in your result. But you also kindly kind of mentioned that how important it is to have a follow-up, because if you were showing your slides where you could really see that from the diabetic clinic to LVP, the attendance against referral was really low. So these are real challenges, and you kind of put importance on AI and everything. So I just wanted to ask you, probably because you have already explained, but in the interest of time, and also as I told you that the whole group is predominantly working in community. We know how AI is placing a role in our own life, including ChatGPT, everything. And there is no doubt AI is not going to help, or I mean, and everybody is kind of accepting AI will be beneficial. But then there always have, especially for smaller eye hospitals and at smaller level players, they have a problem. Where do they start? You have a lot of models which probably they can adopt. So your expertise of using AI extensively and really getting result, I wanted to ask you, like, maybe kind of a take home for the people who are already here attending your presentation. What are the role really AI can play in terms of diabetic retinopathy screening in community? Maybe kind of a very, very summarized way to the crisp message to this audience. Over to you, Dr. Padmaja.
Thank you, Subeesh. I would say that the first point to start with is in the community eye hospitals, when they start, they should view it as a, for example, whenever we are very much used to cataract screening programs, and which are like a vertical link. You go to the point and you finish and everything. Whereas whenever we use diabetic retinopathy, we need to have a horizontal linkages. So in this, whenever we think of AI in a solution, so definitely fundus photography has brought a paradigm shift in the way we can do the diabetic retinopathy screening. It is objective, cost effective, accurate, and if it is placed at either at the primary health centers or at the physician clinic, that is going to be very cost effective. But at the same time, in my own project, as I shared, that whenever we have bought these cameras and the AI tool, there need to be an element of AI audit also. And there should be a term called human in the loop. So the one who are handling these cameras, whether it could be technician, it could be an optometrist or a paramedical personnel, should have some amount of the basic training about what is diabetic retinopathy, and then your ability to get a good quality images. And there are now cameras which are giving you the AI assisted. They're also giving a feelers that, okay, this camera quality is good, image is good, and you can go ahead. Because AI is always as good as the quality of the image. So if the data, for example, the validation is not good, or if the image quality is not good, AI is not going to work. And the human in the loop, whoever it may be, either it is at the vision technician level or whoever is handling, they should play a very important role. And that way we can actually maximize the performance. And AI audits are important both from the data scientist perspective and also from the provider, healthcare provider, whoever using the camera. That is where I use the word called software maintenance. So it's in the annual maintenance of these cameras, we should ask for both hardware maintenance as well as software maintenance, because AI may cause false positives, unnecessary referrals, and then we may have to tweak the algorithms. This is what I would say in a nutshell. Thank you.
Great. Thank you, Dr. Padmaja. I think it clearly emphasized on how important in this scenario also humans are. And I think we really appreciate the good work happening at WP under your leadership. And we definitely wish everything, and please keep us kind of inspiring and guiding further. Thank you, Dr. Padmaja. Moving to Dr. Thomas Cherian, he also has given a wonderful lecture on whom all we should screen and how we do. I mean, I would really appreciate the details you have gone into, starting from basic and to explaining how things are going to happen, and the way you have explained how do you convince your patients when they come to the clinic, once they identified with the problem, then how do you kind of convince them to come for the follow-up care? Because this is something we really have difficulties where probably we may go to community, identify a person with diabetic retinopathy, but end of the day, after referral, they are not reaching to the hospital. So that is something is happening. So a lot of things can be there in the community, but most importantly, I think we all looked at government or policy level decision making also, because this, if you look at currently the NCD clinics, especially for diabetes and hypertension, there is tremendous momentum. If you go to any primary health center, you can find these facilities available. You have specific NCD clinic having medication continuously provided. So there are a lot of momentum is happening in NCD, but with respect to eye care, especially for diabetic retinopathy, this is not happening. So I wanted your insight on what are some recommendations probably we can give to government sector and authorities, so that they can kind of look at this also as a priority where it reach to a last mile in the community.
Thank you, Subeesh. Things have improved to a certain level that awareness about diabetes is good in the community. Patients go to NCD clinics or to the physicians or to the diabetologists to seek treatment for diabetes. But the same thing is not happening with diabetic retinopathy. And till that happens, we need to create some amount of coercion in screening and picking up diabetic retinopathy. For example, if a patient is seen in the NCD clinics, just like what Vishali ma'am said, we can have those green, amber, and red. And I would suggest to the government authorities, especially I have made this recommendation to the government of Kerala to be implemented in the NCD clinics of our state, that a diabetic patient's file could be closed only after a screening for retinopathy has been done. It could be either a manual screening by an optometrist or an ophthalmologist, or it could be a telemedicine-based screening, or it could be an AI camera-based screening. Whichever method of screening, it's immaterial. but some sort of screening has to be done for the file of a diabetic patient to be closed. Unless and until it is done, the file remains open and it's incomplete, and it should be picked up in audits that these files are incomplete. And once a diabetic retinopathy is picked up, you mean to say the green, amber, and red, if it's red, it immediately goes into the treatment mode. If it's an amber one, again, it needs to be screened. So when should be the next screening done? That also has to be placed on record. So if this patient requests the next screening to be done in 6 months, it has to be noted, and in 6 months it should pop up. If the next screening is to be done at 1 year, that should pop up at 1 year. And such things, if it is done at the policymakers level, then we can go a long way in picking up diabetic retinopathy among the diabetic patients and taking them for treatment.
Great.
So it should be an obligatory thing. That's it.
Okay, I think that really convey how important to keep doing our advocacy work, because end of the day, that's what matters, where at a higher level also we need to ensure people are hearing the importance of this, the immediate problem, where you rightly keep mentioning about irreversibility. Unlike cataract and all, there is a higher chance of irreversibility happen when you really identify it late. So definitely we would do, and we really appreciate the work Little Fever is doing in this end, and we wish every best for your organization and yourself. Moving to Dr. Vishali Gupta from PGH Chandigarh, and she also has rightly mentioned about how important having a system, but equally people are getting involved on. So I think all of the speakers was talking about one important thing, which is about the gap between identifying a patient in the community and then having them come into your hospital on a regular basis based on their clinical requirement. So there are a lot of roadblocks, and many of the institutions even still struggle to bridge that gap. How do you really, identification is a challenge, but even after identifying a person at the community, they're not really coming to the hospital for further treatment and follow-up, which is very evident. So I just want your valuable input, Dr. Vishali Gupta, on how do we really look at the roadblocks and probably looking at more effective ways so that we can kind of close it. Over to you, Dr. Vishal.
Thank you, Dr. Subeesh. I will talk only about the government setting. Government has all the intentions to, pick up the diabetics and do the screening. So we have no doubt about that, and they do put in the cameras. However, what we need as a policy, for example, before even referral, we brought the technicians to our center. We trained them for 2 weeks. We certified them that they are competent to take good photographs. They went back to their center, which was mostly primary health centers. Government had put in the cameras and they started doing it. And within 6 months, majority of them were transferred here and there, and the next person was not trained and the camera just went unused. That is number one roadblock. Number two roadblock is that even if they identified the patient, they did not tell the patient exactly where to go. We did not have a list of all the doctors who would be covering Ayushman Bharat in their facilities, in the vicinity of this, where they could say that, okay, you can go there. So as a result, they told everybody to go to PGI. And the person may be 500 kilometers away, or, the way the things are. So when they refer to PGI, we have published actually this in BGO. We quizzed them. The first was that they found it very difficult to get the online appointment. When they reached here, there were a lot of queues and they just got lost. And the third, they realized that it was not a one-time affair. They will have to keep coming back again and again. And they just, the family or anybody, they did not get that kind of a support. And even if people reached here, the injections which are not a part of Ayushman Bharat are not being given free to the patients. And that becomes a very major roadblock. You cannot manage diabetic retinopathy unless you can give them injections. and the injections were not a part of it. They were told to pay for it, which they could not do, or they were kind of apprehensive what to do. So I think we should have a very clear plan before when we develop the policy.
Absolutely. Strongly agree. And I think all these challenges are across, and as institution and individual, we keep trying to overcome that so that the last mile reach is happening. I really wish every best for PGH Chandigarh and your organization. And moving to our last excellent speaker, Dr. Judith, she's also from Little from Angamali. We've been talking about at different stages at community, you need these other things to be happen. But one important thing is communication to the patient. If you look at the disease spectrum, diabetic retinopathy, where you need a patient who is completely aware and willing and kind of understanding the importance of regular follow-up care and everything. So my question to you is, let's say after a patient is identified with diabetic retinopathy, what are the essential communication should be delivered beyond explaining the disease and its clinical management, which is very important of overall management of diabetic retinopathy? Over to you, Dr. Judy.
Thank you, Sushil. Actually, once a patient is being diagnosed with diabetic retinopathy, be it in the early stages or in the late stages, I would recommend that those patients within the early stages, they should be aware that it's not just taking treatment for diabetic retinopathy is the main cornerstone of getting their disease cured. The glycemic control also plays a very important, crucial role. Actually, we have many of our, in our department, in our hospital, many of the ophthalmologists, when they detect with the early onset, even the earlier diabetic retinopathy, they'll call up for follow-up, and then they send us to us also for getting the glycemic control, for getting the sugars under control. So that plays a very important role. Usually, since diabetes is a silent killer, and you have no other symptoms, unless the patient is being hit with a rod, like being blind or having severe vision loss, which bothers him with his work or with her work, she never comes to the ophthalmologist. Only that time they realized that if they had controlled their sugars previously very good, they would have not fallen into this trap. So the diabetic control plays a very crucial role, and especially when the patients are being detected with early diabetic retinopathy, I think that it's a very crucial statement that every ophthalmologist should send those patients back to their local physicians or to the doctors whom they are attending to have a tight glycemic control and get it into control to prevent further worsening of the diabetic retinopathy status. And as we physicians also, when we see a patient first, actually in type 1 diabetes, after the diagnosis of type 1 diabetes, within 5 years, we refer for a diabetic retinopathy screening. And the diabetic patients at the onset itself, when they're first diagnosed or when they come to the diabetologist or endocrinologist for the first time, we send them for diabetic retinopathy screening, because we don't know what stage they are, or since when has this diabetes occurred to them. We don't have the actual role or actual data. So as physicians and as diabetologist, we should also recommend our patients that they should have a diabetic retinopathy screening. Just like Dr. Thomas Chirian sir told that if you have to close the case, you should have a diabetic retinal screening for every diabetic patients who are coming to your clinic.
Thank you. I think your answer kind of highlighting again the importance of having integration with the health system. I mean, diabetic retinopathy cannot be managed in isolation. We do need integration with the health system, and probably we have to work more hand in hand. And all of the speakers have given their excellent insight for all the participants. I could see almost 150 participants are there. I'm really sure that they really got benefited with this excellent insight, which been accumulated over years with practical exposure and implementing programs various part of India. So once again, I really wanted to thank all of the excellent speaker for your valuable time and insight. Maybe Dr. Hina, for you also an excellent coordination, ensuring everyone is here and presenting on time. And we still have 15 minutes. So maybe you can take up some questions, which is from the participants if they have, and we may conclude accordingly. Over to you, Hina.
Yeah, thank you, Subeesh sir, for the panel discussion. Right now, we have only one question in the Q&A box. It's just a simple question. Someone who is an optometrist, but they wanted to apply for pre-registered UK optometrist. So they are asking like, will experience certificate of Ayushman Bharat scheme hospital will be
This is a
acceptable?
very out of the context question.
Yeah, this is out of the box
Indeed, even.
question.
Probably we can answer him separately because it has nothing
Yeah.
to do with diabetic retinopathy.
Yeah,
Should
definitely.
not,
Yeah.
maybe if the other question comes in, we were discussing about the integration. I'll just wanted all of you to, because this is one thing if we can do probably for every hospital, especially how do we really work with probably even in your presentation you have model where you are working with diabetic clinic, you are working with physician, but it's not happening everywhere. So there are some blocks which is somehow many institutions are not able to overcome. Probably very few are able to overcome and work along with physician, work along with diabetic clinic, work along with NCD, but not everyone is able to. So let's say we have a hospital working in eye care predominantly. There is no integration at right now. They do get diabetic retinopathy patient and they do treat them, but there is no integration. So what will be their maybe first 2-3 immediate step to maybe to walk towards that integration? I'll start with Dr. Patmaja. Maybe if you can just.
Yeah. So I think integration is the key. We all understand. And we also know that if we put any money in the physician-led model, that will be the most cost effective. But as I said, in this 1 year of my operational experience with the current ongoing project, I think what we need to have in terms of sustainability, because during projects, okay, we can afford free screening and everything, but the physician to do the screening for diabetic patient walk-in, it should be part of consultation package. It should not be viewed as a separate test. As Dr. Cherian said that, we will not close the diabetic patient file until the eye is examined. So it should be just like blood pressure estimation, should be like a weight estimation or other vitals. Even the fundus screening should be done. Being invested in the fundus photography, this thing, so they can actually make it as a part of their consultation package so that the patient also doesn't view it as a special test.
Absolutely.
And having a vision check and this visual acuity estimation and the fundus photo testing should be part and parcel of integration. And community hospitals can look at, as I said, they should have a horizontal linkages. So whether it could be a diabetic clinics or it could be in villages, could be a physicians who are dealing with the diabetes or even registered medical practitioners or ANMs which are causing diabetes registries. So like that, if we have horizontal linkages, we know where the diabetic patients are coming in and should have a fundus photography based type of a model.
Absolutely. Thank you, Dr. Patmaja. Dr. Thomas, you have some additional insight to share on this.
Yeah. Of late, we are getting a lot of referrals from nephrologists because nephrologists, as far as I understand, have been sensitized for diabetic retinopathy. The moment a patient reaches a nephrologist clinic with an impaired renal function test, a diabetic patient, the patient is referred to the ophthalmology department for a screening for diabetic retinopathy. This sort of awareness or this sort of education has to be imparted to the endocrinologists, the physicians, and the general practitioners, because all of them see diabetes. So unless and until that happens, the integration never happens. Patient will go to a primary care physician or a diabetologist or an endocrinologist, get his diabetes controlled and goes back without a screening. So ophthalmologists need to penetrate the systems in the endocrinologists group, in the physicians group, and give them awareness about diabetic retinopathy and educate them so that they know they know all the science, but that extra push has to go from the ophthalmologist side to get the patients out from their clinics to our clinic for screening and treatment of diabetic retinopathy.
Absolutely. I think more and more dialogue should happen, and maybe we might be able to show a win-win scenario where this will indirectly help their overall practices in the long run. Probably that's a scenario we may have to bring. Dr. Vishali Gupta, you have some more insight to share on
No,
this.
but I agree with Padmaja that asking them to refer the patient is not going to help because patient is normal as far as his eyesight is concerned. So diabetologist will very half-heartedly say, okay, go and show a ophthalmologist. And the patient also has no problem. So he's not motivated enough. So we probably need a model where the screening is done there itself, whether it is the primary contact, whether it is the chemist who's giving the medicine for diabetes, or it is a diabetes clinic, whatever. They screen it, they code it, and then they tell that you have a very serious problem. And in the ideal system, within their EMR, there should be appointment available for the near XYZ retina specialist, or at least the contact where the patient is guided to go. So, like my endocrinology department at PGI sees about 5 to 600 diabetics every day. They do not send it to us for screening, and if they send, our retina clinic already has 400 patients every day. We are not going to screen them. We are going to tell them. So I think something has to be done. We need to train our nurses, and it should be a part of nursing curriculum. RPGI, we are making a plan to train all the nursing students for taking photography. We have to train our optometrist, our MSc optometry student, BSc, sorry. They all are trained to get photographs. So we have to inbuilt in the curriculum, the MBBS. Doctors should be able to do photographs so that it becomes at the point of care screening and not referral to ophthalmologist or a retina for screening. Ophthalmologist only for treatment for the vision threatening.
Absolutely. A lot of task shifting and sharing has to happen. And I completely that's a way to deal this overwhelming burden. But Dr. Judy, you have any points to add on this?
Like just like how Dr. Padmaja, Dr. Thomas Chiran, and Dr. Vishal had told, yeah, to to incorporate diabetic retinopathy in diabetics care, it's a very difficult task. Like usually diabetic patients, if they have neuropathy symptoms, or if they find the creatinine is very high, they get panicked. But a person with a very just blurring of vision, or you just tell them to go to an ophthalmologist, they just tell that okay, then we'll do it afterwards, right? So I think so in our model or in our setup, just like as we test this HbA1c every 3 months. Like initially, if you just tell the patients to go to the ophthalmologist, get your eye done, get these tests done, get that test done, they might not get convinced. So at least, even if it's not at the first stage, at least after 3 months, after getting the sugars control, or if we usually do this urine ACR or HbA1c every 3 months or every 6 months. In that time, if you could convince the patients that you should also get your eye checkup, even whatever stage of diabetes they are, I think so that will help us to get a knowledge about the retinopathy status in the diabetic patients. Like not at the initial, like when the patient comes itself, when you bombard them with investigations and everything, they won't get convinced. And so to incorporate in our routine practice, like once in 3 months or once in 6 months, you also get your eye checkup, also get done. You get it done. And if you get it done, and if it's in the later stages, to have an immediate appointment with the retina specialist for the further interventions, I think so that will be much more feasible in our setup.
Yes, we completely agree on that. I think we are ending towards the conclusion. We have 3 more minutes to go. So with that, I think we have an excellent session where we could really get a lot of insight, which is practical and implementable. And I hope the participants might have gained a lot of insight, and wish every participant to go ahead and implement at least few of the idea these legends have shared, which will again benefit your own community, and then come back again as insight and expert. That's a visual cycle we all see. Keep doing and keep learning and keep improvising our own intervention practices. With that, I hand it over to Dr. Hina to officially conclude the session. Over to you, Dr. Hina.
Yeah, thank you, Subeesh. Thank you all for attending to this webinar cum panel discussion, and we appreciate your time, engagement, and your thoughtful questions. A special thanks to our speakers for sharing their expertise, and we also thankful to our corporate advisory board members for their support. We hope you found the session valuable, and we look forward to seeing you at the future events. Thank you once again. Thank you to all the experts for their valuable inputs. And thank you, Mr.
you.
Subeesh, for the coordination and for moderation.
Thank you,
Thank you.
everyone.
Thank you, everyone.
Thank you, everyone.